In this video, we're going to walk through 10 high-yield cardiovascular NCLEX-style questions designed to sharpen your clinical judgment and test-taking strategies. These questions focus on key concepts you're likely to see on exam day, including heart failure, hypertension, medication management, and priority assessment findings. As you go through each question, pause, think critically, and apply your nursing knowledge before reviewing the correct answers and rationales. Let's get started. Question 1. A client with chronic heart failure is prescribed lisinopril and spironolactone. Which laboratory finding would require the highest priority follow-up before administering the next doses? A. Sodium 133 milliequivalents per liter. B. Potassium 5.8 milliequivalents per liter. C. Creatinine 1.3 milliequivalents per liter. D. BUN 24 milliequivalents per liter. Correct answer, B. Potassium 5.8 milliequivalents per liter. Rationale: lisinopril, an ACE inhibitor, and spironolactone, a potassium-sparing diuretic, both increase serum potassium, placing the client at high risk for hyperkalemia and fatal dysrhythmias. A potassium of 5.8 milliequivalents per liter is clearly above normal and requires holding one or both medications and notifying the provider. Question 2. The nurse is reviewing discharge instructions for a client starting on amiodarone for atrial fibrillation. Which statement by the client indicates a need for immediate further teaching? A. I will call my provider if I develop a dry cough or shortness of breath. B. I should use sunscreen and protective clothing when I go outside. C. If my skin starts turning blue-gray, I'll just cut the dose in half. D. I will have regular eye exams while on this medication. Correct answer, C. If my skin starts turning blue-gray, I'll just cut the dose in half. Rationale: amiodarone has serious toxicities: pulmonary, thyroid, hepatic, skin, ocular, and any adverse effect requires prompt communication with the prescriber, not independent dose adjustment. Clients must never change the dose on their own. A blue-gray discoloration is a known toxicity that requires provider evaluation. Reporting a dry cough, shortness of breath, using sun protection, and getting regular eye exams are all appropriate safety behaviors for amiodarone therapy. Question 3. A client receiving intravenous nitroprusside for hypertensive emergency develops confusion, tachycardia, and a new metabolic acidosis on arterial blood gas. Which action should the nurse anticipate first? A. Decrease the infusion by half and reassess in 30 minutes. B. Stop the infusion and prepare to administer sodium thiosulfate. C. Notify the provider and request a higher dose of nitroprusside. D. Administer an intravenous bolus of normal saline. Correct answer, B. Stop the infusion and prepare to administer sodium thiosulfate. Rationale: nitroprusside can cause cyanide toxicity, especially with high doses or prolonged infusions, and presents with altered mental status, metabolic acidosis, and cardiovascular instability. The priority is to stop the offending agent and administer the antidote, sodium thiosulfate, per protocol. Simply decreasing the dose or giving fluids does not address the underlying toxicity and delays definitive treatment. Increasing the dose would worsen the problem and is unsafe. Question 4. A client on chronic digoxin therapy presents with nausea, anorexia, and new-onset visual halos. The apical pulse is 64 beats per minute and potassium is 3.0 milliequivalents per liter. Which prescription should the nurse question? A. Administer scheduled digoxin dose. B. Obtain a serum digoxin level. C. Start potassium supplementation. D. Place the client on continuous cardiac monitoring. Correct answer. A. Administer scheduled digoxin dose. Rationale: nausea, anorexia, and visual disturbances, yellow or green halos, are classic early signs of digoxin toxicity. Hypokalemia increases sensitivity to digoxin and dramatically raises the risk for life-threatening dysrhythmias. So, giving more digoxin is unsafe. The nurse should hold digoxin, notify the provider, obtain a digoxin level, correct potassium, and place the client on monitoring. Orders to obtain a level, start potassium, and monitor rhythm are appropriate and should not be questioned. Question 5. A client taking metoprolol for chronic stable angina reports feeling dizzy and very tired. Vital signs: blood pressure 96/54, heart rate 48 beats per minute, oxygen saturation 97% on room air. Which medication change should the nurse clarify with the provider? A. Decrease metoprolol dose and add a long-acting nitrate. B. Continue metoprolol and add diltiazem for better rate control. C. Discontinue metoprolol and start propranolol instead. D. Hold all anti-anginal medications for 24 hours. Correct answer. C. Discontinue metoprolol and start propranolol instead. Rationale: the client is already bradycardic and hypotensive. Switching from a cardioselective beta blocker, example, metoprolol, to a non-selective one, example, propranolol, would likely worsen bradycardia and hypotension and increase adverse effects. This order does not address the hemodynamic instability and is unsafe, so it requires clarification. Dose reduction or adding another anti-anginal can be reasonable if done cautiously with monitoring. Holding all anti-anginals for 24 hours could precipitate angina or ischemia and is generally not appropriate without a very specific reason. Question 6. The nurse is caring for a client on heparin therapy for a new deep vein thrombosis who will transition to warfarin. Which finding indicates the best timing to discontinue the heparin infusion? A. The client's INR is 1.8 after 2 days of warfarin. B. The client's PTT is within therapeutic range on heparin. C. The client's INR has been 2.5 for 24 hours while still on heparin. D. The client has no leg pain and reports feeling much better. Correct answer. C. The client's INR has been 2.5 for 24 hours while still on heparin. Rationale: when bridging from heparin to warfarin, both medications are continued until the INR is within the therapeutic range, usually 2.0 to 3.0 for deep vein thrombosis, for at least 24 hours. Stopping heparin too early, before warfarin reaches steady therapeutic effect, increases the risk of clot extension or embolus. A single INR of 1.8 is subtherapeutic, even if heparin is therapeutic. Clinical improvement in leg pain alone is not a safe marker to discontinue heparin. Question 7. A client with coronary artery disease is prescribed simvastatin. Which statement by the client requires priority follow-up? A. I'll take this medication at night. B. I sometimes drink grapefruit juice with breakfast. C. I will report any unexplained muscle pain or weakness. D. I know this medication helps lower my LDL cholesterol. Correct answer. B. I sometimes drink grapefruit juice with breakfast. Rationale: grapefruit juice inhibits cytochrome P3A4 and can significantly increase serum levels of many statins, including simvastatin, raising the risk of severe myopathy and rhabdomyolysis. This interaction is potentially serious and requires immediate teaching to avoid grapefruit products. Taking the statin at night, understanding that it lowers LDL, and reporting unexplained muscle pain are correct and desired behaviors. Question 8. The nurse is reviewing medications for a client with heart failure and chronic kidney disease. Which new prescription would cause the greatest concern? A. Enalapril in a client with baseline potassium of 4.7 milliequivalents per liter. B. Furosemide in a client with baseline sodium of 135 milliequivalents per liter. C. Spironolactone in a client with baseline potassium of 5.0 milliequivalents per liter. D. Metoprolol in a client with baseline heart rate of 78 beats per minute. Correct answer, C. Spironolactone in a client with baseline potassium of 5.0 milliequivalents per liter. Rationale: spironolactone is a potassium-sparing diuretic. In chronic kidney disease, the kidneys already struggle to excrete potassium. So starting spironolactone with a K of 5.0 milliequivalents per liter places the client at very high risk for dangerous hyperkalemia. ACE inhibitors like enalapril can also raise potassium, but a single value of 4.7 is less immediately concerning than 5.0 plus spironolactone. Furosemide tends to lower potassium and can be appropriate in heart failure with careful monitoring. Metoprolol is not directly nephrotoxic and is commonly used in heart failure if heart rate is adequate. Question 9. A client with atrial fibrillation is receiving diltiazem. Which assessment finding indicates the medication is achieving the intended therapeutic effect? A. Blood pressure increases from 110/70 to 134/88 millimeters of mercury. B. Heart rate decreases from 132 to 78 beats per minute at rest. C. PVCs appear frequently on the cardiac monitor. D. Respiratory rate decreases from 22 to 10 breaths per min. Correct answer, B. Heart rate decreases from 132 to 78 BPM at rest. Rationale: diltiazem, a non-dihydropyridine calcium channel blocker, slows AV nodal conduction and is used in atrial fibrillation primarily for ventricular rate control. A decrease in heart rate from rapid, 132 beats per minute, to controlled, around 78 beats per minute, indicates the drug is working as intended. Increased blood pressure is not the goal and may be undesirable. New frequent premature ventricular contractions or significantly depressed respirations would be adverse, not therapeutic, findings. Question 10. The nurse is preparing to administer the morning cardiac medications. Which client requires clarification of the prescription before administration? A. A client on isosorbide mononitrate with a blood pressure of 100/60. B. A client on metoprolol with an apical pulse of 88 beats per minute. C. A client on furosemide with potassium of 2.9 milliequivalents per liter. D. A client on warfarin with an INR of 2.4. Correct answer, C. A client on furosemide with potassium of 2.9 milliequivalents per liter. Rationale: furosemide is a loop diuretic that causes potassium loss. Administering it to a client who is already hypokalemic can worsen hypokalemia and precipitate serious dysrhythmias. The nurse should clarify the order and anticipate potassium replacement before or along with further diuresis. A BP of 100/60 for a client on isosorbide and an apical pulse of 88 for a client on metoprolol are generally safe parameters. An INR of 2.4 is within therapeutic range for most clients on warfarin for DVT or atrial fibrillation. If these cardiac pharm questions helped you think like the NCLEX, hit like, subscribe, And share this with a nursing friend who's grinding for boards too.